And welcome to the workshop, Graft-versus-host disease, Advances in Prevention and Treatment. My name is Sue Stewart, and I will be your moderator for the workshop. Before we begin, I'd like to thank Sanofi and Incyte, whose support helped make this workshop possible. It's now my pleasure to introduce to you today's speaker, Dr. Iskra Pusic. Dr. Pusic is an associate professor in the Division of Oncology in the Department of Internal Medicine at Washington University School of Medicine in St. Louis, Missouri. Her research focuses on long-term complications after transplant, particularly graft-versus-host disease, as well as survivorship. She is a member of the Chronic GVHD Consortium, the Clinical Trials Network, and the Center for International Blood and Marrow Transplant Research Committees on GVHD and late effects. Please join me in welcoming Dr. Pusic.
Thank you, Sue, very much for this nice introduction. So I will talk to you today about graft-versus-host disease and advances and challenges in prevention and treatment. And as a brief overview of our learning objectives today, we are going to talk about prevention, and then as of treatment, we are going to touch on available and approved new drugs to treat acute and chronic GVHD, and also on drugs in clinical trials, on some side effects associated with therapies used to treat and prevent GVHD, and on ancillary GVHD therapies. So when we start talking about GVHD, and as I promise, I will not use abbreviations here in this talk, except this one. I think that you all can stand the shortenage for graft-versus-host disease. So just explaining what is happening when we transplant stem cells, I want to start by saying what happens when we, for example, transplant an organ such as kidney. Our main worry is that the host, meaning the recipient, the patient, immune system, will recognize that organ as foreign and reject it, resulting in a rejection of that transplanted organ. However, when you transplant stem cells, those stem cells are immunologically active. So aside from having the host immune system trying to reject them, you can also have this transplanted stem cells recognizing the host, the patient, as different from them. And that is what we call graft versus or against the host disease, known as GVHD. And when we talk about GVHD, it comes kind of in these two flavors, acute and chronic GVHD. And we used to think of acute GVHD as any GVHD happening between day 0, which is the day of your transplant, and day 100. However, we know that acute GVHD can happen also after day 100, and then we call it now late acute, which can be either recurrent after it has resolved previously, or persistent, or new onset, meaning that it starts after day 100, even though the person didn't have it before day 100. And incidence overall is there's a wide range, and primarily because of different prophylactic strategies we now use. It affects primarily 3 organs, which is skin, gastrointestinal system, and liver. And when we think pathophysiologically what's going on, it is known mostly as inflammatory, which means inflammation as an underlying cause. When we talk about chronic GVHD, we used to think of chronic GVHD as any chronic GVHD that is happening after day 100, but now knowing that this process of chronic GVHD is a separate process from acute and has somewhat different features, we also know that classic chronic GVHD can really happen even before this mark of day 100. And the incidence is somewhere 40 to 50%. It can affect essentially any part of the body, and we think of it more as a systemic disease that in many instances resemble autoimmune diseases and eventually can lead to fibrosis and sclerosis. And in some situations, people can have features of both chronic GVHD and acute GVHD. And in those situations, we will call it overlap GVHD or overlap syndrome. And here I'm showing this to you in a more schematic way where you can kind of see this flow from acute to chronic and then situation of overlap syndrome if you have both of acute and chronic features. When you look at organs involved, as I said, in acute GVHD, you're going to have skin, gastrointestinal system, and liver. And for example, in skin with acute GVHD, mostly this will be red, kind of sunburn-like rash on your skin. In the mouth, you can have mouth sores, also inflammation of your gums, diarrhea, loss of appetite, nausea, vomiting, and then elevated liver enzymes that can then lead to yellow tinge of your eyes or skin. In chronic GVHD, when skin is involved, even though sometimes you can have changes that you might call rash, eventually you will have more change in the texture where skin will appear more thicker or drier if you want, and sometimes leading to poor mobility of skin, resulting then in for example, decreased range of motion in your joints that can come from skin thickness. It can affect your eyes with dry or sometimes teary eyes, with pain, blurry vision. It can affect mouth with mouth sores and ulcerations, and sometimes again from this thickening around the mouth and the skin, it can cause trouble opening your mouth. It can involve lungs, which will typically result in shortness of breath, cough, being more susceptible for infections. And also one organ that is relatively often involved are joints and muscles, where people can have pain and stiffness and sometimes a lot of cramps in their muscles. Also gastrointestinal system and genitals. And when we think about graft-versus-host disease, as I showed you on that initial slide, you need to have, in order to develop GVHD, you have immune cells from the donor in the graft. And those cells can attack the recipient and cause GVHD. But also, the same cells help recognize cancer cells and destroy these cancer cells. And this is something that we know as graft-versus-leukemia or graft-versus-tumor effect. So GVHD could be removed if you would try to remove all the active immune cells from the donor, from the collection from the donor. But when you do that, if you completely remove donor immune cells, you potentially increase the risk of relapse. So it's this balance between GVHD and this GVL on the other side. And as you will see in some of my next slides, really our efforts in prevention and treatment is to kind of try to harness these two reactions and allow, on one side, graft-versus-leukemia effect to go on while harnessing graft-versus-host disease. So I will first touch a little bit on our methods of prevention. And prevention strategies really start before any GVHD develops, which means around the time of transplant. And when we think how to design our transplant strategies, that's the time to incorporate prophylaxis. And there are several strategies that we can use. One of them is to manipulate the graft. So by selective removal of those immune cells that are capable of causing GVHD, that's one way we can do it. But also, we can try to enhance the graft with the cells that might be beneficial and try to help with this graft-versus-leukemia effect and minimize graft-versus-host disease. And this is by adding certain types of T cells that could have that effect. And these are, just for example, some of the ways we can do it. And this is by depleting these naive T cells that are capable of causing GVHD, or alpha beta T cells, or by selecting for CD34 cells. And here there is completely new ways of thinking and doing this by doing complete graft engineering. And these are some trials that are currently open, and some of these studies have already been published with very encouraging results where you can enhance graft or even do completely new graft engineering with great results, with resulting in decreased acute and chronic GVHD. And these trials are available across many institutions that do stem cell transplant across the world, really. The other way of thinking about prevention strategies is by using medications. And use of tacrolimus or cyclosporins that are known as calcineurin inhibitors, plus methotrexate, known as tacromethotrexate, it has been for years, to say really decades, the backbone of doing transplants. And sometimes we might add some additional medications such as mycophenolate, known as MMF or Salsep, to it. We would often add ATG, particularly in situations when we transplant using graft from unrelated donors. Sometimes we might substitute calcineurin inhibitors with sirolimus. So these are just some of the examples of the drugs that we use as medications to prevent GVHD. And these are all very good immunosuppressive drugs. However, they have various side effects, and I listed some of them here more as an example. And the other problem with them is that they ultimately do not induce immune tolerance. And really, for long-term effect and GVHD-free period, what you need to achieve is immune tolerance where the host and graft kind of live together. And these drugs are relatively poor in achieving immune tolerance. The other drug on the block, or I wouldn't say it's a new drug, but it's a new technique, is use of post-transplant cyclophosphamide. And cyclophosphamide we also use as a chemotherapy drug, but it is a great immune suppressive drug. And it was this technique was initially used in haploidentical transplants. And haploidentical transplants are transplants when you have a half-matched donor, for example, a sibling who is not fully matched but is half-matched, or a parent or a child. And in order for such a transplant to work, we were, and not cause horrendous GVHD in the recipient, the use of post-transplant cyclophosphamide is designed to give it on day +3 and +4 after the infusion of stem cells, with the idea that in that time period, you're going to have these alloreactive T cells that are capable of causing GVHD that are going to be rapidly proliferating and dividing. And this medication, cyclophosphamide, has the ability to act on these rapidly dividing cells and destroys them, as you can see on this upper line. While the cells that are not in this part of the cycle where they're rapidly dividing, such as stem cells, for example, can go on and not be affected with post-transplant cyclophosphamide and continue to engraft. So your stem cells can engraft, while those rapidly dividing alloreactive T cells that can cause GVHD are destroyed with cyclophosphamide. And this has really enabled us to now increase our donor pools by using donors that are only half matched. Some considerations when using post-transplant cyclophosphamide is that it can delay immune reconstitution. And what this really means is that patients will have somewhat delayed count recovery and maybe during this time period somewhat increased risk of infections. And also this drug can have some added cardiac toxicity. So what has been done since this has been used is several studies, and I'm going to underline one of the studies that was run through the network called BMT-CTN. It's a clinical trial network running transplant trials. The number of the trial was 1703, and it was now comparing use of this drug not anymore in haploidentical transplants, but in unrelated donor settings when the reduced intensity conditioning was used, and it was compared to that backbone I mentioned with tacrolimus and methotrexate on one side, and on the other side, regimen with post-transplant cyclophosphamide together with tacrolimus and MMF. And what it showed was here, this was survival without GVHD or relapse, where you can see in the orange line that post-transplant cyclophosphamide had 52.7% of patients who had this relapse and GVHD-free survival, as opposed to 35% of patients with use of tacrolimus and methotrexate. And also, if you look at acute and chronic GVHD incidence, you can see that it was lower when PtCy was used. You can see this orange arm below the blue arm, so lower incidence of both acute and chronic GVHD. And after that study now, use of post-transplant cyclophosphamide has really become a part of GVHD prophylaxis that most centers now will use with reduced intensity conditioning transplant when they use unrelated donors. Often, many centers will use it even when there is fully myeloablative conditioning. The other agent that is relatively new is abatacept. That's a T-cell costimulatory blocker, and it has been tested with tacrolimus and methotrexate in unrelated donor transplants in the setting when it was even so-called mismatch unrelated donors, so not fully matched, but 7 out of 8 mismatch unrelated donors. And you can see here abatacept is in red. You can see that survival without severe acute GVHD was significantly higher, both when it was used in 7 out of 8 mismatch or just regular unrelated donors. And if you look at the grade 2 to 4 acute GVHD incidence, you can see that it was lower, the red line, when abatacept was used compared to standard GVHD prophylaxis in blue. So FDA approved that regimen for use in GVHD prophylaxis in 2021. what do we really do now in a real-world practice? We have ATG that I didn't really talk about, but that is something that it is anti-thymocyte globulin that we have often used in situations particularly of unrelated donor transplants or mismatched transplants. We have post-transplant cyclophosphamide, and we have abatacept. And what should you use and how you should think about these three agents that we have as new strategies for GVHD prophylaxis. One study that was done looking at 7 out of 8 mismatched unrelated donors, comparing abatacept to regular prophylaxis with ATG, showed that abatacept was significantly better than regular prophylaxis using ATG in addition. And this was presented as an abstract by Dr. Keene at ASH. And the other study I'm showing here that looks complicated, but what I just want you to concentrate on is this was comparison of abatacept without ATG and PtCy without ATG. So essentially comparison of abatacept and PtCy, and there was no significant difference in these two approaches, even though on these graphs abatacept looked a little bit better. Statistically, it was not significant, meaning that we really don't quite know whether abatacept approach or PtCy approach is better, and really more studies and more data are still needed, and studies comparing these regimens will be coming. But what we do know in a way is that ATG is slowly kind of falling out of favor as opposed to these other two regimens that we now have and use. And what I want to leave you with when we think about GVHD prevention strategies is really the answer is clinical trial. And there are many new trials testing new agents, and if your institution has a clinical trial and you or your loved ones are about to go through transplant, consider participating in one of these trials. When we talk about treatment of acute GVHD, it is determined by the severity of acute GVHD for the first-line therapy. And mild skin GVHD, mostly skin, usually what we will do is we will continue or restart prophylactic medications. Primarily here, I mean medications like tacrolimus, sirolimus, or MMF. And we might use topical steroids for skin GVHD. For patients who have more severe skin GVHD or have involvement of gastrointestinal tract or liver, they will require use of systemic agents, and the agents that is still considered standard of care as a first-line therapy are steroids, plus restarting your tacrolimus or cyclosporine. And use of ancillary therapies such as topical steroids for skin, and then other medications that we might use for gastrointestinal GVHD such as beclomethasone and budesonide. The other approach is that sometimes we will replace tacrolimus and cyclosporin, particularly on somebody who was on these medications for a long time and his GVHD is getting worse. We might replace them with sirolimus. There are other approaches without steroids, such as using only sirolimus as a first-line agent, and there was a study testing that showed no necessarily benefit of using only sirolimus but in GVHD, but the benefit that there was less steroid-induced adverse events. And again, I think the answer will be clinical trial where new agents can be tested, either adding them to steroids or as a steroid-free approach. And when we talk here about steroids, I just want to take a minute to say that for acute GVHD, typical dose that we use is 1 to 2 milligrams per kilogram per day, divided usually in 2 doses. And then if GVHD is improving, you can start tapering that dose. Using doses that are higher than that are not really more effective, but can be more toxic. And here are some of the side effects of steroid treatment that I'm sure many of you know much better than I do, and these are the reasons why we try to steer away from steroids, taper them, and think of approaches that can be steroid sparing. What can happen when we start first-line therapy? People can respond, and that response can be sustained and GVHD can resolve. On the other side, people can have these flares where they respond initially, but then as you taper their medications, their GVHD can flare and symptoms can return. Or it can continue without any significant response. And in those later two options, these are the patients who might need second-line therapies for acute GVHD. And typically, we think of it for people who don't respond to steroids after 5 to 7 days or who progress after 3 days of treatment with high-dose steroids. So the drug that deserves to be mentioned here is ruxolitinib, that was tested in several trials and then compared to best available therapy hand-to-hand, and it showed that partial or complete response by day 28 was 62% in ruxolitinib arm as compared to 39% in any best available therapy that was essentially dealer's choice. And based on that study, ruxolitinib was FDA approved in the United States and later on in Europe for acute GVHD. So how do we, in summary, approach treatment to acute GVHD? Essentially, if you have skin manifestations, yes, and then you don't have gut GVHD and your skin is mild, this is the situation where you can go to topical steroids alone. Any other combination, even if you don't have skin manifestations but have just gut or liver, or if you have both skin and gut and liver, or if you have severe skin GVHD, you will require systemic therapy, typically, as I said, with steroids. If that fails, second line agent is ruxolitinib. If ruxolitinib fails, there is a variety of options that we can use, and this list here is not complete. And really, we don't know, and I don't have enough information to say which one of these agents is better. I'm sure different investigators, different institutions might favor one or the other of these agents. But really, National Comprehensive Cancer Network says that there is insufficient evidence to recommend one agent over another. And that's why I think the answer to a situation where you have steroid refractory GVHD is a clinical trial. And in clinical trial, really, there are a lot of agents that are being tested trying to target the cells that are involved in development of GVHD, working on agents that can help with tissue repair, and with all that in mind, avoiding overly broad immune suppression and have more so-called targeted therapy as opposed to just broad immune suppression such as steroids. Chronic GVHD prevention. And here, when I talk about chronic GVHD prevention, really, chronic GVHD prevention and acute GVHD prevention are not completely separable. And many agents that we use for acute GVHD prevention, really, we want them to be able to work on chronic GVHD prevention too. And process that leads to chronic GVHD prevention, even though chronic GVHD, we all think of it kind of as something that happens later. This process begins long before clinical manifestations really develop. And that is why it is important to perform risk stratification early on to identify people who are at risk to develop chronic GVHD later on and intervene early. And in a way, we need to balance the risk of developing chronic GVHD on one side with the risk of graft rejection or delayed recovery of immune system, meaning infections, delayed count recovery on the other side. And again, I keep repeating that, but really developing targeted therapy as opposed to broad immune suppression that can prevent chronic GVHD without really impairing immune system recovery. And it brings us back to that old figure showing this balance between GVHD on one side and graft-versus-leukemia on the other side, where we want to try to harness the cells that are causing GVHD while allowing graft-versus-leukemia or graft-versus-tumor effect to go on. And when we think about chronic GVHD treatments, here what are the goals to, on one side, control signs and symptoms of chronic GVHD, but also to prevent further progression and additional tissues and organ damage, to maintain our anti-tumor effect, and eventually to achieve tolerance between the host and the graft, and hopefully be able to stop immune suppression down the line. Also, to minimize treatment toxicities, because again, all of you are very well aware that those drugs that we use to prevent or treat chronic GVHD have side effects. And eventually, our goal is to decrease mortality and improve quality of life. So when thinking about chronic GVHD, questions that your physician can ask you, but also questions that you can ask yourself, and I listed here 10 questions, are important just because it is important to recognize developing chronic GVHD early on. So these 10 questions are kind of going through the main organs that are involved with chronic GVHD. How does your skin feel? Is it tight? Is it hard? Is there a rash, dryness? Is it scaly? Do you have inability to sweat or keep warm? Do you have hair or nail changes? How are your joints? Do you have any limited range of motions, muscle cramps? How about eye dryness or excessive tearing? Do you need to use artificial tears? How about oral dryness? Any change in taste, food sensitivity? Do you have any ulcers, difficulty opening your mouth? Ask about swallowing liquids, swallowing pills, swallowing hard food. Does the food get kind of regurgitated, kind of comes back when you try to swallow it? How about shortness of breath or cough? Ask about vaginal dryness. That is something that often goes unasked in our clinics. And also inquire about any unexplained weight loss or inability to gain weight, ongoing nausea, vomiting, diarrhea, or poor appetite. And when we deal with chronic GVHD, again, mild chronic GVHD can usually be handled with local therapies, topical therapies. And I encourage you here to look at this paper showing and talking about ancillary therapies that might have some good suggestions in how to handle some of these issues that are adjunct, and we use them in addition to systemic treatment of chronic GVHD. More moderate or severe chronic GVHD involving more organs that with more moderate or severe involvement will require systemic immunosuppression. And here, for a long time, again, the first agent used to be corticosteroids in little lower doses than with acute GVHD, that again, you continue and then you slowly taper. And to date, there were many studies testing other agents, but for first-line therapy, no other agent has been proven to be more beneficial than steroids. However, complete response is only about 50%, which is inadequate. And what we need are clinical trials. And what you will see, and if you discuss with your providers, there are going to be, and there are already, ongoing clinical trials testing novel agents now as a first-line therapy for chronic GVHD. So agents that are already approved, and I will talk about that on the next slide, for refractory GVHD, we bring them up in the frontline setting and use them as a first-line therapy. And other options are steroid-free approaches or comparing and doing randomized trials of these different drugs plus minus steroids. So when initial therapy doesn't work, then we will use some of the secondary therapies. So these are for people who progress, who develops toxicity, or if there are some insurance issues. And the chance that a person who is starting the first-line therapy will never need an additional therapy is only about 20%. And many people who start the first-line therapy will require other therapies or will require therapy being restarted in next 3 to 4 months. So really, management beyond initial therapy has been very much trial and error. And when we think about what should we do, should we add another agent? Should we put a patient on the study? And how do we choose? Again, NCCN guidelines list a variety of drugs, but there is no really consensus how to use them. And it will depend again on physician or center experience, on toxicity, on cost, on patient preference. And currently, in 2024, there are now 3 drugs that are FDA approved for use of secondary therapy in chronic GVHD. All of these drugs were really tested in open-label trials, so these were not blinded studies. Only ruxolitinib was in a comparator arm with dealer's choice. However, and if you look at these agents, I listed here they're all pills, except leave the 4th column for a second. These 3 drugs, ibrutinib, ruxolitinib, and belumosudil, are all pills. Ibrutinib and ruxolitinib have been used for other indications, and belumosudil is a new drug that has been developed particularly for GVHD. But they all have approximately same overall response. And the 3rd drug, axatilimab, is not yet FDA approved, but it has shown also very promising response and has been presented as a new drug potentially for treatment for chronic GVHD. It's an IV drug, intravenous, comparing to the other 3 agents that I talked about. So when in the last minute or 2, I just want to say, how do we choose among them? And I know that this is a question that probably most of you will have. And what is the standard of care with all these drugs that we now have available? And really the answer is, briefly, I don't know. And much more experience is now needed after these drugs were approved. And knowing whether one of them is better for certain specific manifestations of GVHD, in what order to use them, how to switch among them. None of these answers, for none of these questions, I really have an answer. This still varies between different investigators, but the answer to this question is that we will need more evidence and really clinical trials. And I think we can return to this slide with question and answer where I can discuss any one of these questions in more details. And for the end, I just want to say is that chronic GVHD is a chronic disorder. And we know that often it's not possible to completely taper off people of immunosuppression. Many people need to continue at some low grade. For example, many people stay on steroids for a long time. So is stopping immunosuppression really the measure of success? Or we can develop new therapeutic approaches that will be well tolerated and might be able to be used as a maintenance long term, where really success will be measured as an arrested progression of chronic GVHD with improvement in functioning and quality of life rather than completely stopping medications. And the answer here is that we need more personalized and more biologically relevant approaches using biomarkers and also testing agents at the earliest stages of chronic GVHD. And I can probably stop here, and then as we go through question and answer, I can touch more on other questions.
All right. Well, thank you, Dr. Pusic. That was an excellent presentation. A lot of questions, very thought-provoking. We will start the question and answer session now. As the operator indicated, if you have a question, type it in to the box on the left, and we will try to get to as many of those questions as we can. Let's start with the first question that came in, and that was, what type of GVHD symptoms have you seen in patients with an HLA match of 7 out of 10? And I think maybe the broader question is the greater the mismatch, the worse the GVHD, or is there no relationship between those two?
So there is definitely a relationship, and we used to think always that we need to have as good match as we can, and if we had patients who were more mismatched, such as 7 out of 8 or 9 out of 10, we would be concerned that these people are at a higher risk of developing GVHD, particularly both acute and chronic. However, this has changed now with the availability of post-transplant cyclophosphamide and abatacept. And if you have a donor who is mismatched, your provider will probably, almost certainly, use one of these agents to try to prevent development of GVHD after transplant.
All right. This person would like to know whether you can develop joint and muscle GVHD as late as 8 years after transplant.
Well, chronic GVHD can last for a long time, and I for sure have had patients and have patients who have issues with some ongoing chronic GVHD for a very long time, meaning decades after the transplant. So I think it would be somewhat unusual to have no signs of chronic GVHD and then all of a sudden develop muscle issues that you would then attribute to chronic GVHD without any other signs and symptoms for 7 years prior to that. That I would think I would consider other possible causes. But people who have had ongoing issues with chronic GVHD for sure can have ongoing muscle pains and cramps even 7-8 years out of transplant.
All right. This person comments that Jakafi costs almost $20,000 per month and is wondering at this point in 2024, are there really a lot of people that are on it, and is there anything that can be done to reduce the cost?
Yes, I am aware that in some situations insurance companies might not approve or there are significant copays involved with these medications, and this is still a significant problem. And I still think that Jakafi or ruxolitinib is a great drug, and there are some patient assistance programs that we try to use and try to find a way to obtain these medications for people who have high copays. That is one slide that actually I kind of cut it down a little bit at the end, but one slide here I wanted to bring up is that we are all stakeholders in this process, and with these drugs being approved by regulatory agencies, we will really need to work with payers to find optimal models where these drugs that are now approved can be, the patients can have access to them. So there is no question that better options are needed for patient assistance or for these drugs to be available through insurance for patients.
That is absolutely true. Okay, the next question, is there any evidence that simple measures like exercise or diet make a difference in the development or treatment of GVHD?
Absolutely. This is a great question. I think that diet and exercise are definitely adjunct therapies in GVHD, and I think that stretching exercises can help prevent, to a certain extent, development of fibrosis and keep range of motion going. I think that there is a lot of muscle wasting in people who are on steroids, and exercising and helping build muscle mass are all really, really important in trying to maintain your physical strength. Diet also is very important as an adjunct method in GVHD.
All right. The next person says, how long does it take for Rezurock to really start to work? I began it on the 1st of this year, and I've been on prednisone since 2017. I have adrenal insufficiency, so I can't get off it. I have mouth issues, fascia issues, and wasting, weakness, and cramping.
Well, I think I didn't get from the beginning, how long was that person on Rezurock?
Started at the 1st of this year.
So it has been now approximately 5 months. So I would say when you start a new medicine for chronic GVHD, I would say it needs at least 3 months before you would say it doesn't work. So you need to give these medications some time to work. Sometimes it takes longer than 3 months to start seeing some effect. If by now you think that there is no any improvement despite you being on Rezurock, then I think you should discuss with your provider and see whether there is any possibility to get on any trials trying any of the new medications used for chronic GVHD. The medication I mentioned briefly, axatilimab, there has been a trial, and that trial is now closed, and this drug might be FDA approved in the coming year for steroid refractory chronic GVHD, and there for sure will be other trials testing it for chronic GVHD. So I would strongly encourage inquiring about that and potentially participating in one of these trials.
All right. Next question. Do people with chronic GVHD have to be on immune suppressants for the rest of their life?
So not necessarily. The hope is that with time there will be immune tolerance where there will be the balance and kind of tolerance of the host and the graft, where people will be able to discontinue their immunosuppressive medications. However, there are some people where when you start tapering immune suppression, they will develop some worsening or a little flare of GVHD. So it kind of varies from person to person, but some people might require some degree of immune suppression. But again, I'm talking broadly because these new drugs are not that much immune suppressive. I would call them more immunomodulatory because they kind of modulate your immune system. And some people might need to continue them for a long time or for life if needed, but hopefully at the lower doses, and hopefully with these new medications with time we'll be able to taper people completely off the drug. However, with time might be a long process, and this can take months and months, if not year, to taper somebody completely of medications for chronic GVHD.
All right, this is a rather lengthy question. Let me see if I can summarize it. This person had a transplant in May of 2020 with an unrelated donor that was a match on 10 markers. And in 2021, he developed GVHD in his eyes and saliva glands. He has been on Rezurock and Jakafi, and since August, he's been taking some new infusion treatment. He doesn't say which one. He's wondering whether these treatments should improve what he's experiencing or just prevent other symptoms from developing.
No, I would say both. The hope is that they will improve the symptoms that that person had. And I want to underline here, when I was talking about trials of ruxolitinib, belumosudil, and axatilimab, improvements that were seen in these agents. For example, the last drug that was tested, axatilimab, on that trial were patients who previously failed ibrutinib and ruxolitinib and belumosudil. Similarly, on belumosudil, people already failed both ibrutinib and ruxolitinib, some people. So it is possible that some of these newer agents that are used, that even though you have failed some of the prior therapies, you still have a chance to responding to some of these newer agents. And the hope is that, yes, your symptoms will improve, but it will also stop development of new chronic GVHD symptoms.
All right, this person wants to know whether Enbrel injections are good for gut GVHD.
Well, for sometimes we use, it's a type of treatment that we might sometimes use for gut GVHD. Yes, it definitely can lead to some improvement in gut GVHD.
All right. And then this person is 7 years out after transplant and has smoldering GVHD in her eyes and extensive scarring. Her eye doctor is pressing for systemic immunosuppressants, even though she doesn't have GVHD symptoms elsewhere. Is there any particular drug you would suggest in this situation?
I have had several such patients in my practice who did not have significant signs or symptoms of chronic GVHD anywhere else but in their eyes. And I had success with both Jakafi, ruxolitinib, and Rezurock in that situation. However, it might not always work, and I definitely think that this person, I think it's worth a try. I would agree that we, aside from everything that this eye doctor is doing for topically for the treatment of eye GVHD, I think that this could require, and I would try systemic treatment for eye GVHD. And again, I think this should be done kind of jointly through the discussion of this person's eye doctor and transplant physician.
All right. This person wants to know, is there a way to identify people who have a higher risk of developing chronic GVHD, like age, comorbidities, family history? Are there any factors that increase your risk of developing GVHD?
Well, there are risk factors that we know that can potentially lead to high risk of GVHD, such as older age of the patient, older age of the donor, sometimes female donor, particularly for the male recipient, the difference in matching, in HLA matching. However, many of these situations we can't really account for. If some people have several donors that are potentially an option, then we will try to choose a younger, fully matched male donor. But that's not always an option, and sometimes we have limited options, and we might not have any. Some people might not have any unrelated donors as an option, and then we might need to use a sibling who might already be older. So we know there are some potential risks. However, we cannot always account for them. However, that being said, there are a lot of papers with guidelines how to choose the best possible donor, and if you do have some options, how to kind of go among them, particularly now when we know that with these new novel methods of GVHD prevention, we could use family members who are not fully matched.
All right, and then unfortunately this is going to need to be our last question. We're running out of time. This person wants to know she still needs her measles and mumps revaccination, but due to GVHD she's been told not to get them. Is that going to be true forever?
Well, I would agree that people who have active GVHD and who are on higher doses of immune suppression during that time should not get vaccinations right during that time period. That goes aside, usually we will vaccinate people for flu and for COVID regardless. But these vaccinations that you mentioned, that this person is inquiring about, I would postpone them until GVHD is contained and we can at least somewhat taper immune suppression. And so I hope it's not forever. I hope we will be able to contain this person GVHD, and then once the GVHD kind of cools off and we lower the immune suppression, then the person will be able to be vaccinated.
Great. And with that, I think we have to close. I want to thank Dr. Pusic for your very helpful presentation, particularly in the Q&A section. And I also want to thank the audience for the very excellent questions that you posed. I think we all learned a lot from the individual questions that were posed. Please contact BMT InfoNet if there's anything else we can do to support you, and enjoy the rest of the symposium.